Hi, everyone. Welcome to the MACS, Maryland Addiction Consultation Service webinar on, now I've gotten my waiver, now what? We're going to get started in just a few minutes. We'll let people sign on and then get going. Hi, everyone, and welcome to Maryland Addiction Consultation Services, MACS, our webinar on now that I've gotten my buprenorphine waiver, now what? So we are live here at the University of Maryland. This is going to be recorded, so if folks want to go back and look at this later or let your colleagues know, we will send out a link to how to get to it after the webinar. Also, just as a reminder, everyone is muted, but if you do have a question or something that you wanted to bring up, please feel free to type it into the chat box. We will be taking questions at the end, but if you have something time sensitive or urgent, please feel free to send it in. We have somebody moderating for us. So let's get started. Just as a reminder, MACS is a service that provides support to primary care and specialty prescribers across Maryland in not only identification and treatment of substance use disorders, but now also more broadly in chronic pain management. All of our services are free. It includes phone consultation for clinical questions, resources and referral information, education and training opportunities related to SUDs and chronic pain management, assisting in the identification of addiction and behavioral health resources. And as mentioned, it is administered by the University of Maryland School of Medicine and funded generously by the Maryland Department of Health, Behavioral Health Administration. And we have our phone number and our website address, which has lots of other information at the bottom there. Well, today we're going to talk about office-based opioid addiction treatment. I got my waiver, now what? And my name is Yngvild Olsen. I serve as a medical consultant to MACS and the Behavioral Health System Baltimore and BHA. I am also a provider and prescribe buprenorphine, as well as work in a specialty addiction outpatient clinic, and I'm an internist and primary care physician by training. So we're going to briefly just go through a little bit of the landscape, where we are kind of with respect to this issue, and then delve into some systems issues related to getting started with prescribing, who, what, when, how of operations and some tracking. And the question that has often come up in some of the trainings we've done is, when is enough enough? And what do I do at that point? And we'll wrap up with some take-home messages and take your questions. So just as a reminder, we all know about the issue related to opioid addiction and overdose in the country, as well as here in Maryland. But just to show you that in the through the third quarter of 2018, so this is not the full year of 2018, but the latest available data from the health department in Maryland, that the number of opioid-related overdose deaths continues to increase. Interestingly, we now see that the number of heroin-related deaths, however, has been falling over the last couple of years, as well as the number of prescription opioid-related deaths that have occurred in Maryland. So what is driving this ongoing opioid overdose epidemic? Well, we know now that it is really the number of fentanyl-related deaths. And I want us to just keep this in mind as we go through and talk about some of the clinical issues that come up in prescribing buprenorphine to people in office-based settings who have an opiate use disorder. So how are we doing in terms of waiver prescribers? Because clearly you all hopefully either have gotten your waiver, you're thinking about getting your waiver, or you are trying to engage prescribers, potential prescribers, to get their waiver. And where are we with the demand and the need to really be able to treat people who have an opiate use disorder in Maryland? Because as I showed you, we are still experiencing a wave of overdose fatalities, but that is really just the tip of the iceberg when it comes to people who have an opiate use disorder. We know that the number of non-fatal overdoses, even though we are still don't have great estimates on how many people that has occurred for, and we don't have great estimates for how many people in Maryland have an opiate use disorder, but we do know that estimates from Baltimore City, for example, say that around 20,000 people have an opiate use disorder in the city. And we know from national data that there are many patients with an opiate use disorder who don't get treatment, effective treatment in particular. So in Maryland, this is data from MACS and the Behavioral Health Administration as of the beginning of February. We now have an estimated 1,297 waiver prescribers in Maryland. So not nearly enough, because even if all those prescribers were prescribing at their limit, we still might need an additional prescribers to really meet the demand, the growing demand. And as you can see on the slide, that the vast majority of those waiver prescribers in Maryland are indeed physicians, but we have a growing cadre of nurse practitioners and physicians' assistants who are now waivered to prescribe buprenorphine. This is data that from national surveys that was relatively recently done by SAMHSA that found that, unfortunately, out of the 4,000 so newly waivered physicians, some of whom actually have gotten their waiver but asked to increase their the number of patients that they could prescribe to, and physicians who responded to the survey, 75% reported having used their waiver, but only 13% of those clinicians were prescribing at or near their limit, and they were prescribing to a mean of about 11 patients per month. That was of the clinicians with a 30-patient limit. That number didn't change that much, relatively speaking, in terms of percentages, when they looked at people, the physicians who were prescribing or allowed to prescribe to 100 or 275 patients. So essentially what we have is we have a growing cadre of physicians and nurse practitioners and PAs who have gotten their waiver, but and a large percentage of them who reported having used it, but we still need to have closer to 100% using their waiver. And of those clinicians who have been prescribing, that only a minority of them actually have been prescribing at or near their limit. So what are some of the barriers to really using buprenorphine, their buprenorphine waivers? So the study that I mentioned by Jones and McCann's had found that there are a number of different barriers to physicians and prescribers using their buprenorphine waiver, as can be imagined. But unlike in the past, where particularly insurance reimbursement. And here in Maryland, we're lucky because insurance reimbursement is much less of an issue here than it is across the country. That now really lack of access to addiction specialists for consultation, as I've highlighted all of the statistically significant barriers here on the left side with red arrows. And in the blue arrows really are pointing to those that were significantly if you really look at these low odds ratios, even relative to some of the other barriers. Lack of access to addiction specialists for consultation was a big barrier identified by the respondents in the survey. Lack of confidence in managing patients with opiate use disorder, resistance from practice partners or staff, and lack of institutional support to using the buprenorphine waiver was a big one. And then getting practice started, or not even having a current practice site. Obviously, if you don't have somewhere to actually see patients, that's a big barrier. But I point these out partly because hopefully what we'll be able to do by the end of today is to give you a little more information to try and address some of these barriers. And while today may not necessarily answer all your questions, that hopefully we can give you some information that will make it easier for you to really overcome some of these barriers if you identify with many of these as barriers to your own use of your buprenorphine waiver. So let's think about kind of then what do you need really when you're thinking about starting any type of new practice, right? Or any type of new initiative in your practice. What do you need? Well, you have your waiver, or the prescriber in your practice. There's a prescriber that has their waiver and now wants to start treating people with opiate use disorder. And it's not as easy as just pulling out that prescription pad and starting to write. The first thing you really want to kind of think about is, what is my model? How am I going to do this? Am I going to fully integrate this into an existing practice, like a primary care practice, for example, or a pain management practice? And what are the implications for that? Do I think that maybe having a separate program, a completely separate program, is that what I am considering? One caveat to thinking about that, or one consideration for that, is the potential application of additional confidentiality regulations that separate addiction treatment programs would need to adhere to if you have a completely separate program. And we can talk more about that. The third kind of large model that has developed for this is what's being really referred to as an integrated collaborative care model. And that model often uses nurse care managers or behavioral health specialists as some of the glue to help prescribers not have to do this on their own completely. And Massachusetts has really been a forerunner of the nurse care manager model of integrated collaborative care models for the integration of buprenorphine and the treatment of opiate use disorder in office-based setting. And they started out with researchers at the Boston Medical Center surveying all of the waivered physicians across Massachusetts back in 2005. And one of the barriers that was most frequently cited in that study had to do with insufficient nursing support. Because in many primary care practices, nurses or MAs or other ancillary staff provide a lot of support to the physicians and other medical providers who see patients in those settings that are fast-moving, high volume, and the prescriber really needs to use their time wisely. They also asked that if the barriers were improved, would you be now more likely to prescribe? And it turned out that 54% of never prescribers and 67% of previous prescribers reported that they would do so if those barriers got removed or improved. And so Boston Medical Center started an office-based opioid treatment model they even started before they did the survey, but they'd started with a handful of physicians and a nurse care manager that really was there to support the physician prescribers and patients. And with the survey data in hand, they expanded and created something called the OBOP-B collaborative care model that they then introduced and integrated into community health centers across Maryland. And currently, there are at least 56 healthcare sites that also have received technical assistance on that model since 2016. And essentially, the workflow and staffing that they've developed is a 1 FTE RN to support 3 primary care physicians, or a ratio of 1 RN to 125 patients. They have a medical assistant as part of the team and a program coordinator. And the nurse care manager essentially serves as that glue. So they do initial screening, they participate in chart review, they do a lot of the buprenorphine induction, education, and assessment, and rely on the physician then to do the H&P, to make medical decisions about the medication, to generate and sign the prescription, to obviously back up the nurse as appropriate and as needed. But the nurse care manager really has a very central role in this model. And it's been evaluated. So this is data from a paper on the collaborative care model that was in Archives of Internal Medicine in 2011, where they found that essentially treatment retention of patients over a 12-month period was around 50% in this model, and really was considered a success. That only 2 patients here had to be administratively discharged due to disruptive behavior, and that about 6% transferred to methadone in an opioid treatment program because they were unable to stabilize on buprenorphine. They did have about 30% loss to follow-up, which is something that the model is and Boston Medical Center is continuing to look at. But they really now have been able to treat close to 8,000 patients between 2007 and 2013. They saw an increase in the number of physicians who were waivered to prescribe buprenorphine. And they also found that average hospital admissions and emergency department visits reduced per OBOT enrolled patient by about 50%. So from a health policy and health policy decision maker perspective, that's a really good data point and a good outcome. Now, every model has its challenges and successes, and the paper that outlines this model talks about some of the provider and staff resistance that they really had to overcome, that the funding sometimes is siloed, and that initial and ongoing training is really important to keep reminding and reviewing how the model is working. And I think one of the hardest perhaps to really overcome in busy primary care practices and other busy practices that are not specifically focused on addiction treatment is that there are many other priorities. Patients have other priorities, prescribers have other priorities, the organization has other priorities. And so sometimes it's easier just to co-locate those services within an organization. But that in terms of the successes, that really being able to integrate buprenorphine and opioid use disorder treatment into an existing primary care practice, pain management practice, really is able to leverage existing and then add new resources. And that being deliberate about integration and models created to foster that, and using data to drive the prioritization of this type of treatment with key champions at the helm has been really successful, and they've been able to then see some good outcomes. So you want to kind of identify your model, right? And we talked some about the various different types of models. But regardless of what model you select or your organization selects, you want to make sure that you really have identified your team members. And as we've shown, that could include a nurse care manager. It may also include a medical assistant if you don't have a nurse care manager. The pharmacy, you really want to think about developing a partner with the pharmacy, whether it's on site or in outside of your organization. Thinking about who's going to cover you as the prescriber when you're on vacation or out sick or something happens. A behavioral health specialist is becoming more and more part of the team, whether that person is actually part of the organization or outside of the organization. And having a practice manager or other operations or admin role to really help with those operations documents, developing checklists, working through the workflows it can be really helpful. And the right-hand side of the slide really goes through some of those team member functions. So you can match kind of the functions with the team member, and it doesn't have to necessarily always be the team members that I've listed here. But you want to think about kind of what do you need in order to actually really smoothly be able to take care of patients with buprenorphine. Managing phone calls from patients in the pharmacy, checking in with patients between visits, help problem solve those unexpected situations. Having somebody who can provide additional support to patients on visit days, that has been found to be helpful in many settings. Tracking urine tests and their results, reinforcing treatment agreements, expectations, really being able to provide that backup coverage for when the primary prescriber is out. And then, as I mentioned, developing the operations documents and checklists so that everyone on the team and everyone in the organization has an understanding of how the workflows are supposed to go. And this is similar to if you're tracking hemoglobin A1Cs and diabetes management, for example, in a primary care practice. So what is the physician, the nurse practitioner, the physician assistant, the waiver prescriber's role in all of this? So some of the roles that you could think about include having the prescriber see the patient if they're ready to start medication, kind of a no-brainer. Really just doing a brief review of the person's recent opiate use history, treatment expectations, how to take the medication, as was discussed hopefully in the initial waiver training that you all did, and then reviewing the cows, writing that prescription for the initial dose of buprenorphine or naloxone. And if you recall back to the original training, that often we start with a 4 milligram, anywhere between 2 and 4 milligram, but very often now a 4 milligram dose, and then proceed on from there. Making sure that, that once you've written that prescription, then having the patient fill it at the pharmacy. And that's where some of the ancillary staff also come in. And then the physician, the prescriber, really has to decide, am I going to have the patient stay and take the medication? And maybe it's my nurse or behavioral health specialist or MA who then helps monitor that in the office, or am I going to have the patient take the medication at home? That's a decision that you as the prescriber are going to need to make. I think the recommendation, at least the recommendations that we've made in the past in the initial waiver training, is that home induction now is very much the norm, but initially, maybe even with the first couple of patients, that having the patient stay in the office and just take the medication there, that might enable you to get some better sense of exactly kind of how the patient's going to do with the medication, what happens after people take that medication, but we can talk more about that. And then the part of the other flow is that as the prescriber, you don't necessarily need to see the patient or check in with the patient, for immediate follow-up. But if you have the nurse check in about 3 to 4 days after the initial dose, repeated cows, then maybe the nurse could come to you and you might need to adjust the medication and give a refill for 1 week, or just have the patient come back and see you in a week or so. One of the nice tools that that many practices now have used is to really lay out those workflows. And there's an example here that I've included on the slide. But the workflow really includes concrete steps with all the different functions to be performed. Which of the team members is going to be responsible for taking that action, performing that function, and then at what point are there decision points or associated actions that need to be taken. So for example, if you look here, that this clinical pathway, the nurse here is actually the initial person who interacts with the patient. And there's a triage point here that says either is the patient appropriate for medication-assisted therapy in our setting? And if the answer to that is no, then they get referred to other resources. If the answer is yes, then there's another step. And here in this example, there's a coordinator that is part of the team that then takes on the role of scheduling the intake and assessment. I'm not saying that you have to do it this way, but this is an example of just how you can use these workflows to really plan out exactly how you're going to do this even before you get started. The other part of one of the operational steps is looking at kind of how am I going to identify the patients with an opiate use disorder who I want to then treat. And this is going back a little bit in the process. So there are some settings where they want to kind of do this as a pilot. They want to just kind of try their hand and work out some workflows and work out some kinks. And so they elect to actually start with existing patients. And they have a system and they kind of know who those patients are. If you don't have a system or want to even try starting with new patients, thinking about a process that can incorporate a few questions into your medical or behavioral health encounter, otherwise also sometimes known as SBIRT, is another way of meeting kind of and doing that screening and identification. And I'm not going to get into a lot of this area, but just as a reminder that you want to have a process by which you're going to identify patients with an opiate use disorder who may be then appropriate candidates for treatment with buprenorphine. And so the NIDA, one quick question screener: how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? That is a quick way to just screen and identify people who may be good candidates for and who may be at risk for an opiate use disorder. And then adding the screener for alcohol use, as we'll see a little bit later, that we want to also make sure that we identify some of the other substance use disorders and other substances that patients may be using. In terms of starting buprenorphine, as with any medication, as with any treatment, we are treating a diagnosis. And that is the same with opiate use disorder. So whether or not you use an initial brief screener or some way of identifying patients with opiate use disorder, you want to have the diagnosis listed in your documentation. One way to do that is to actually just take the opiate use disorder diagnostic criteria from the DSM-5 and create either a screening tool or a checklist or some way within your documentation and your workflow to then make that diagnosis. And because the diagnostic criteria span 11 criteria, and the definition includes a problematic pattern of opiate use leading to clinically significant impairment or distress, that having this in some way incorporated into your workflow so that you can remember it, the patient is aware of it, the other ancillary staff is aware of it, is often helpful. So once you've actually kind of either made that diagnosis or you are you've done a kind of a quick screen, right? That responding to a positive opiate screen or diagnosis is really then where the medications and the treatment options come in. And the recommendation now really is that we have informed consent discussions with our patients around this treatment. And so whether it's the provider, so this could be a provider role, or the nurse care manager, reviews the responses to that screening tool with the patient and offers options, that whoever team member does that this is then part of the one of the steps on that workflow, that kind of chart that you're doing. Because you could imagine that there are some patients who they would love the opportunity to actually get treated with medications within your practice. But there may be some who say, you know, I'm not really all that interested in that. They might instead opt for a referral for an in-depth assessment and treatment outside of your practice. Or they may have such complex opiate use disorder and other diagnoses that you may actually elect to refer them for treatment outside of your practice. Alternatively, there could be people who you want to treat and who would be good candidates for treatment with buprenorphine in your practice, but for whom you really believe that referral for other behavioral interventions may also be helpful for them. And so having that as part of that discussion is often helpful. And so if the patient then selects option one, so yes, I want to get treated here for my opiate use disorder, the recommendation really is to review the agreement prior to starting the medication. Sometimes this can happen in a just in a practical way, and sometimes it's hard because the patient may be in really significant withdrawal, and you want to make them physically feel better so they can concentrate more on what you're talking about. But having and using a patient prescriber agreement, while there is not tremendous empirical evidence that this makes or contributes to differences in outcomes, it is a recommended best practice, because what it can do is outline the expectation for the patient and for the prescriber, how the prescriber will respond to the patient. And it can serve as part of that informed consent that we talked about. It, for example, can include alternatives to buprenorphine, right? So what happens if, you know, this treatment doesn't, patients don't respond to it, and maybe a different medication is needed, such as cocaine, such as methadone, for example. Sorry. What I was thinking of in terms of cocaine was that, you know, if patients are using cocaine and if somehow the office-based practice is not an appropriate setting or not a good fit for patients, and they need more intense monitoring or resources, that can also be outlined in the agreement. So I've included just an example of one here. We will have more templates and tools kind of on the MACS website, and there are other places also to get more examples of these types of agreements. But just to suffice it to say that that these are some of the things that you want to think about when you're creating or applying one of these templates to your practice. And I would also recommend updating and reviewing this at regular intervals, for example, annually, and particularly if issues arise. It can be very helpful. So when you then get to start the medication, as we've talked about, nurse-driven models have been developed and tested. There are some counselor-driven models that are also out there that can be effective. One of the things that has been found to help is to schedule slightly longer visits with patients for that initial visit to start their medication. And if you remember back to the waiver training, the recommendation is to counsel the patient to not take or use any opioids within 12 hours prior to the visit, particularly that really refers to short-acting opioids, and particularly short-acting prescription opioids, if that's the issue. And then have the nurse, with or without a counselor. So if you have a counselor-driven model, have the MA or have someone do the vital signs on the COWS score, conduct and then score that COWS tool. And then you proceed to then write the prescription kind of based on the COWS score. The other piece of this whole puzzle that often comes up is tracking, urine testing, and then ongoing care, and kind of what are some of the tips here that to think about as you're planning to put your waiver into operation. So we talked about the control medication agreements, urine testing. They both are considered best practices for opiate prescribing, not only for opiate use disorder treatment, but also pain. But in terms of urine testing, you really don't need observed urine collection. That is something that often comes up as a question. But using temperature-sensitive cups, not having any bags or jackets in the bathroom, and having then this written out into as part of the protocol and part of the process and your workflow can and expectations for patients can often be helpful. So what if you actually are not going to do observed urine? How do you make sure that the sample, the urine sample, is valid? Well, you can test for creatinine and pH if you're going to send the sample out to the lab. The creatinine will tell you whether it's diluted or not. And just as a reminder that you can do the testing either on site as a point of care test or through a commercial lab. People often ask, well, how frequently do I need to see patients? And one model is to have the patient be seen weekly, either by the nurse or the counselor to check on medication adherence. If you can, have a brief check-in with the prescriber. Buprenorphine doses really should, and patients should really stabilize after about 2 weeks. Sometimes it can take up to a month, but really their COWS scores should go down to 0. Patients should feel much better, not have significant withdrawal or cravings, and also be able to adhere to the expectations of the overall treatment plan. And so refills given weekly until they're stable, then every 2 weeks, and then once a month. Now, in terms of then doing random urines, because that has been the recommendation, that one way to do that is to collect the urine sample at every visit and then just randomly send or test the typical panel that includes buprenorphine and norbuprenorphine. And the norbuprenorphine part, particularly early in treatment, can be helpful just because that will then give you some sense that the patient's taking the medication, metabolizing it, and that they really are understanding kind of what the appropriate medication adherence is really all about. And then obviously checking the PDMP and maintaining a log or an easily accessible list of patients receiving buprenorphine. That is really this log, or just having some list of patients for whom you're treating actively. That is what the DEA is going to look for when they come in and for a visit, because really their goal is to make sure that the patient limits are being adhered to. So one of the things that I would recommend is that if you are just starting to use your waiver, that you really pay some attention to patient selection. And starting with lower complexity patients. You want to get some good successes under your belt before really taking on patients that may be of higher complexity. So people who have stable housing, consistent transportation so that they can adhere to their appointments, some level of family or other social support, either no or minimal benzodiazepine use, so you don't have to get into that quandary of, oh, the benzodiazepines and the risks of benzodiazepines. Minimal other substance use, including things such as cocaine. Marijuana is something we can talk about because that may or may not fall into whether the person's lower complexity or higher complexity, depending on your comfort level. And then less severe mental illness, if that is present at all. So the other really important piece that your admin and your operations practice manager person is going to want to pay attention to is billing, because clearly you want to get paid for all the services that you're going to be providing. Maryland Medicaid, just as a reminder, does cover and reimburses for expert codes, but even short of that, that Medicaid in particular reimburses for addiction treatment services, whether they're done in primary care or in a behavioral health setting. When you're in primary care, however, typically you are seeing patients primarily for or also for other health conditions. And so those are the health conditions that are then used as primary codes, ICD-10 codes on your billing, and then the opiate use disorder becomes a secondary code. The traditional evaluation and management codes are the ones that are used for billing and claim submissions. When you're in primary care or in pain management and not in a specialty behavioral health setting, you submit those claims to the patient's MCO with the corresponding E&M charge. But in a behavioral health setting in Maryland, E&M billing is then done under the corresponding provider type to Beacon Health Options. So the last thing I just wanted to mention about some of these operational pieces and thinking about this in kind of in a continuum is that once patients have gotten stabilized, then, well, how frequently do you need to see them? And that's going to depend some on your comfort level, some on what other resources you have on your team as to who else can check in with patients, and then clearly also on the progress that the patient is making. One of the ways to think about this is that you can incorporate something called a recovery checkup into visits that you would have with the patients to check their blood pressure, check their how their diabetes is doing, check other health conditions that you might also be treating, and that the components of such a recovery checkup really focus on how efficacious the buprenorphine or what the effectiveness of the buprenorphine, how that's going. So in terms of withdrawal and craving suppression, when the person last misused any other opioids, whether the patient's having any side effects or adverse reactions to their medication. Have there been any significant life events actually that may be triggering some cravings or have caused some disruption in the person's recovery management? What other kinds of recovery-related activities are they engaged in? How are they spending their time? How is their daily life and how is their life going? Checking the PDMP and urine test results. And then if you do have concerns or if there are indications of instability, reviewing those and making some decisions about the treatment plan in terms of the frequency of visits, the length of prescriptions, or other services that the patient might benefit from. So in summary, kind of for this section, really this is about gathering your tools, right? So the screening tools, the diagnostic checklist, the COWS instrument, the patient agreement, your referral sources, where else, if you run into problems, where are you going to refer patients, that urine testing PDMP checking protocol, thinking about who you're going to start with in terms of patient selection criteria, what are the billing related forms and codes that that your practice and your practice manager may need, and then if you're going to choose to use a recovery checkup list, to add that to the toolkit as well. So one of the things about, so this is a list. These are some recommendations as to kind of what you might want to put into place in your practice as you're moving forward with using your waiver. And how do you know when you're ready? Well, there's some different ways of thinking about kind of these types of projects or initiative. And in many organizations, there already is an existing practice transformation or new project process that you can actually use as a platform to also incorporate buprenorphine, opiate use disorder treatment into what you're going to then be doing. You can also do a formal needs assessment, or use some kind of readiness checklist. You could use the one that, if you have all these tools and you've figured out kind of your workflow, maybe that's your readiness checklist. And you can do this within your organization only, or you can get some outside help. And we can point you in the direction of some resources where that might be something that you can ask for if you feel like you need it. So I mentioned that, many of the questions that we get from a clinical perspective is, well, when is enough enough? When I start writing this prescription, that first prescription, what if I run into trouble? And what do I do? So the first thing I would say is that the doses of buprenorphine that you're prescribing, you want to make sure that they're adequate. I mean, one of the things that has been found in several surveys, as well as other types of national data studies, has been that often the doses that we are prescribing are too low for the patient to really be able to stabilize. And that goes for methadone, buprenorphine, in various different settings. And so the dose targets are typically around 12 to 16 milligrams, but there may be patients who actually need to go beyond 16 milligrams, up to 24 milligrams of buprenorphine to really be able to stabilize their opiate use disorder. And just remember, however, that buprenorphine is not a panacea, and that there are other substance use disorders that may develop or recur. If the patients now stabilize their opiate use disorder, a past history of a cocaine use disorder may pop up. And that the opiate use disorder itself may actually either remain unstable or may also recur. And that there are other co-occurring conditions, psychosocial issues, that may complicate management in an office-based setting. The initial reaction, and often the temptation, is to say, you know what, I'm done, I can't do this anymore, and to taper or then discontinue the buprenorphine if patients aren't doing well or really kind of doing what they are supposed to. And I want us to go back to the data I showed you at the very beginning, which was that the mortality rates from fentanyl in Maryland are just continuing to go up. And also remind you that data such as the one I'm showing you on this slide, we know that the mortality rate from an opioid overdose really dramatically drops when people are in treatment. This is data from a study with methadone, but the same has been found with buprenorphine, that the red bar shows you the opioid overdose mortality during treatment with methadone here, both for men and women, and that it significantly increases when people then actually are discharged or drop out of treatment. And that is just from opiate overdose. And fentanyl now is the thing that we really just want to keep in mind, that patients are extremely high risk for. The other thing, though, I wanted to also just remind us is that we have now been seeing an increase in cocaine-related deaths in Maryland, and alcohol-related deaths. While they have declined some over the last 2 years, that also has been something that has been on the rise. So it's not just the opiate use disorder that we need to be paying attention to, but also all these other substance use disorders. And when patients develop those, that is something that we also have to think about as the prescriber of and treater of their opiate use disorder. Well, how am I going to manage these other substance use disorders? And that really is, to some extent, an individual decision. Depends on your comfort level caring for more complex patients. And you also have to kind of ask yourself, well, what can my practice realistically manage, right? Can I manage having patients come in every week? Can I manage one patient coming in every week, but what about 10 patients? Can I manage more frequent visits with urine testing at each visit? Maybe I can manage, urine testing for 2 patients who come in every week for a period of time, but not any more than that. One of the things we mentioned, the checking buprenorphine and norbuprenorphine ratios. You also want to look at your patient agreement, and you want to review that with the patient, because hopefully you have put something in that agreement that then gives you the appropriate authority or appropriate kind of just medical decision making to say, you know, this is really beyond the scope of what I am comfortable and what we can really handle here in this practice setting. And that before you completely just discontinue the buprenorphine, that you think about the risk of doing that with then the risk of continuing that office-based practice for complex patients. So that's where using your prescriber supports, MACs, other supports comes in, and really trying to pull in the patient supports. Are there family members that can help with this? Are there other individuals that may need to get involved? And if the answer is either no, or, this is really beyond what my practice can handle, looking to then transfer patients to specialty addiction treatment specialists. That could be an OTP with an opioid treatment program with buprenorphine dispensing capability, a residential care if there are other unstable substance use disorders present, or an intensive outpatient program or outpatient program that also can then help continue the medication, or think about maybe are there other options that we need to consider if no other opioid treatment program is available. Thinking about this kind of similar to the way we also think about complex patients with diabetes or heart failure or hypertension. What are the other resources that we need to engage when really wanting to continue care for patients, but they just become too complex for our particular setting or our experience or level of knowledge. So to wrap things up, and then we can take some questions if there are any. In terms of the take-home messages for this, thinking about integrating opioid addiction treatment into primary care, into pain management specialists, into non-addiction treatment specialty settings, it absolutely can be done. It has been done. There are models out there that we can also look to learn from. But it really does require supportive systems, not just waiver prescribers. And so don't feel badly if you feel like, I've gotten my waiver and I really want to use it, but I'm not sure how, because supportive systems are really going to be the key. As part of that system, having a way of identifying appropriate patients and planning and having the key people in your practice at the table, because it really does take a team. And sometimes that team is beyond your own institution to help create networks and create those that workflow. And then using and collecting and using data to help you demonstrate your success and communicating those successes. Even if it's just, I have 1 patient, 2 patients, and I'm starting out with that, and we've really been able to see some good successes in terms of patient care. So I'm going to stop there, take questions. Just as a reminder, the MACS consultation service is a really good support for prescribers, even if you don't have your waiver yet. If you have questions about how to use it, the phone number is on here, the website is on here, and I'm happy to take any questions. And I'm going to show you my face here. I'm sitting here in this nice warm office. And if anybody has a question, feel free to use the chat box. And Anna has put up a link to some of the templates here that where you can find templates for patient agreements, patient provider agreements. And well, if there are no questions, please don't hesitate to email or call us. if you think of something that came up after this webinar, and also feel free to send this link of this webinar to others if you think that they might benefit. So we do have one question that just popped up. If I create a system in the office that includes a mental health specialist and nurse care manager, would that be considered a drug treatment facility? When do you cross the line from office-based prescribing to drug treatment facility? That is an excellent question, and a question that has come up more and more frequently as people try and start using their waiver. So the answer to that is that there are a couple of things that you want to consider. So the first is that if you are holding yourself out as primarily providing a specialty addiction treatment or addiction treatment, and that is the primary purpose of your practice, then you are considered a specialty addiction treatment, a drug treatment facility from the point of view of confidentiality and the special confidentiality regulations that I mentioned at the beginning. So what that means is that you are then considered to be covered by CFR 42 Part 2, which means that you need to have, patients need to be given, or patients need to give specific written consent on a specific form that has specific language that adheres to Part 2 for you to release any information to anyone, whether it's another healthcare provider, anyone. From a licensing perspective, in the state of Maryland, right now, COMAR 10.63 is the licensing and kind of regulation, I should say, the regulation that covers addiction treatment in the state of Maryland. So I would suggest looking at COMAR 10.63. I would also consider that if you are an office who is primarily, your primary purpose is to treat addiction, and you are really not doing any other kind of medical care, it is possible that you would be considered under that COMAR 10.63 that you might be considered a specialty drug treatment facility. That is not entirely clear at this point, and so I would recommend looking at 10.63. It's going to depend a little bit on exactly how your practice is credentialed through insurance, particularly Medicaid. And there are people at the Behavioral Health Administration in the Department of Compliance, as well as in the Office of Healthcare Quality at the Health Department in Maryland that can help answer some of those questions. And I'm happy to talk more offline with individuals who may have more very specific questions related to their particular program. All right. Well, I think with that, thank you all very much for participating in this webinar, and Max will be coming out with a, there's the link to the webinar and the slides from today's webinar, as well as Max will be putting out information about other upcoming webinars in this series. Thanks very much and have a great day.